Trigeminal neuralgia is a neuropathic pain disorder of the fifth cranial nerve, which carries sensation from the face to the brain. Pain arises when the nerve's myelin insulation is damaged, allowing abnormal electrical signaling attacks or sudden, electric shock-like jolts on one side of the face, triggered by light stimuli such as chewing, brushing teeth, or a breeze. Episodes last seconds to minutes but can cluster in volleys, creating fear of routine activities. Diagnosis is clinical, supported by MRI to exclude compressive lesions or multiple sclerosis plaques. First-line therapy is carbamazepine or oxcarbazepine, which stabilize sodium channels and dampen ectopic firing. Blood monitoring is required for side effects. Refractory cases consider microvascular decompression to separate offending arteries from the nerve root, or lesioning procedures. Radiofrequency rhizotomy, glycerol injection, stereotactic radiosurgery that reduce pain by partially injuring pain fibers. Pain education, trigger management, and nutritional support maintain function. Cluster headache is a trigeminal autonomic cephalalgia characterized by severe unilateral orbital or temporal pain with ipsilateral autonomic signs, tearing, red eye, nasal congestion, eyelid droop, and pupil constriction. Attacks last minutes to hours, often occurring at the same time daily during clusters spanning weeks. The hypothalamus drives circadian periodicity. Trigeminal activation and parasympathetic outflow cause pain and autonomic features. Patients pace or rock due to agitation. Acute treatment is high-flow oxygen via non-rebreather mask and subcutaneous or intranasal triptans, which constrict cranial vessels and block neuropeptide release. Preventive therapy during a cluster includes verapamil titrated to effect with ECG monitoring. Alternatives include lithium or galcanezumab. Short steroid tapers can bridge, while preventives take effect. Alcohol reliably triggers attacks during active clusters and should be avoided. Neurostimulation or nerve blocks are options for refractory disease. CRPS is a disproportionate regional pain state following trauma, surgery, or immobilization driven by maladaptive neuroinflammation, sympathetic dysfunction, and central sensitization. Hallmarks include continuous burning pain, allodynia, pain from light touch, temperature and color asymmetry, swelling, sweating changes, decreased range of motion, and trophic changes of skin, hair, and nails. Diagnosis uses the Budapest criteria after excluding alternatives such as infection or neuropathy. Early multidisciplinary care improves outcomes, graded physical and occupational therapy to restore movement and desensitize skin. Neuropathic agents, gabapentin, pregabalin, tricyclics, or SNRIs to reduce central hyperexcitability, bisphosphonates or calcitonin for bone pain, and short sympathetic nerve blocks for diagnostic and therapeutic relief. Mirror therapy and graded motor imagery retrain cortical maps. For refractory cases, spinal cord stimulation modulates dorsal column signaling. Avoid prolonged immobilization. Structured activity prevents contractures and maintains microcirculation, limiting chronic disability. Kidney stones are crystalline aggregates, commonly calcium oxalate, that form when urine becomes supersaturated and inhibitors like citrate are low. As a stone migrates from kidney to ureter, it causes colicky flank pain radiating to the groin, with nausea, hematuria, and urinary urgency. Diagnosis is confirmed with non-contrast CT or ultrasound in pregnancy. Acute management targets pain and passage. NSAIDs reduce ureteral spasm and prostaglandins. Hydration maintains flow. Tamsulosin relaxes ureteral smooth muscle for stones in the distal ureter. Indications for urologic intervention include infection plus obstruction, uncontrolled pain, renal impairment, or stones too large to pass. Options are shockwave lithotripsy, ureteroscopy with laser fragmentation, or percutaneous nephrolithotomy for larger burdens. Prevention depends on stone type. increase fluids to achieve high urine volume, limit sodium, normalize calcium intake, reduce oxalate in susceptible patients, and add citrate or thiazides when indicated. Pancreatitis is inflammation of the pancreas caused by premature activation of digestive enzymes within the gland. Gallstones and alcohol are common triggers. Others include high triglycerides, medications, and anatomical variants. Pain is constant, severe epigastric discomfort radiating to the back, worsened by eating due to stimulated secretion. Diagnosis combines characteristic pain, elevated amylase or lipase, and imaging when needed. Management is supportive. Aggressive isotonic fluid resuscitation to maintain perfusion, opioid analgesia, and early enteral nutrition to preserve gut integrity. Antibiotics are reserved for proven infection. Complications include necrosis, pseudocysts, and organ failure. Etiology-specific steps, removing gallstones or stopping inciting drugs, prevent recurrence. Chronic pancreatitis features progressive fibrosis, malabsorption, diabetes, and neuropathic pain. Therapy includes pancreatic enzymes with meals, fat-soluble vitamin support, celiac plexus blocks, and in select cases, surgical drainage or resection to relieve ductal obstruction and pain. Shingles arises from reactivation of dormant varicella zoster virus within dorsal root ganglia, producing a unilateral painful rash in a dermatomal pattern. Acute neuritis precedes or accompanies grouped vesicles on an erythematous base. Pain mechanisms include viral inflammation and nerve injury. Antiviral therapy started early shortens rash duration and reduces complications. Post-herpetic neuralgia is persistent neuropathic pain after rash resolution due to deferentation and ectopic discharges. Management is multimodal. Topical lidocaine patches for focal allodynia, capsaicin for desensitization, systemic agents like gabapentin, pregabalin, tricyclic antidepressants, or SNRIs to reduce central sensitization, and short-course opioids only when necessary. Nerve blocks can help refractory cases. Eye involvement requires urgent care to protect the cornea. Immunization reduces the incidence and severity of shingles and lowers the risk of long-term pain by preventing neural damage during reactivation. A sickle cell vaso-occlusive crisis occurs when deoxygenated hemoglobin polymerizes, distorting red cells into rigid shapes that block microvessels. Ischemia causes severe deep bone and chest pain, often with swelling and fever. Triggers include infection, dehydration, cold, or hypoxia. Management focuses on rapid analgesia with weight-based opioids, anti-inflammatories, oxygen if hypoxic, and aggressive hydration to reduce sickling. Treat infections promptly and correct precipitating factors. Recurrent crises are mitigated by hydroxyurea, which increases fetal hemoglobin and reduces polymerization, or newer disease-modifying agents that decrease adhesion or hemolysis. Transfusion is used for severe anemia or acute chest syndrome. Chronic complications include avascular necrosis, leg ulcers, and organ damage from repeated ischemia. Preventive care, vaccinations, folate, and routine monitoring reduces morbidity. Education on warm clothing, hydration, and prompt treatment of pain preserves function and shortens crisis duration. Endometriosis is the growth of endometrial-like tissue outside the uterus, commonly on ovaries, peritoneum, or ligaments. These implants respond to hormonal cycles, bleeding and inflaming local tissue, which causes pelvic pain, dysmenorrhea, dyspareunia, and sometimes infertility. Pain arises from inflammatory cytokines, nerve infiltration of lesions, and adhesions tethering organs. Diagnosis is suspected clinically and can be confirmed with laparoscopy and histology. Imaging helps identify endometriomas. Management aims to suppress ectopic tissue activity and reduce inflammation. NSAIDs for pain, combined hormonal contraceptives or progestins to induce decidualization. GnRH analogs or antagonists to create hypoestrogenism, and levonorgestrel intrauterine systems for localized suppression. Laparoscopic excision or ablation relieves pain and improves fertility in selected patients. Adhesiolysis restores organ mobility. Multidisciplinary care, including pelvic floor therapy and neuropathic agents when central sensitization develops, addresses persistent pain and enhances quality of life. Rheumatoid arthritis is an autoimmune synovitis that erodes cartilage and bone, producing symmetric small joint pain, morning stiffness, swelling, and progressive deformity. Inflammation is mediated by autoreactive lymphocytes and cytokines within the synovial membrane, forming a pannus that invades articular surfaces. Diagnosis integrates clinical pattern, inflammatory markers, autoantibodies, and imaging showing erosions or synovitis. Early treat-to-target therapy prevents joint damage. Begin disease-modifying anti-rheumatic drugs such as methotrexate, escalating promptly to combination conventional or biologic agents that block TNF, IL-6, or co-stimulation pathways. JAK inhibitors are oral options, short steroid tapers, bridge flares, but should be minimized. Physical therapy maintains range and splints support unstable joints. Extra-articular disease, nodules, interstitial lung disease, vasculitis requires tailored management. Regular assessment of disease activity guides adjustments to achieve low activity or remission, reducing pain and preserving hand function. Migraine is a neurovascular disorder marked by recurrent attacks of moderate to severe head pain with sensory hypersensitivity. Cortical spreading depression and brainstem dysregulation sensitize the trigeminal vascular system, releasing calcitonin gene-related peptide and other mediators that drive pain and photophobia, phonophobia, and nausea. Identify attack patterns, triggers, sleep change, stress, certain foods, and aura symptoms. Acute therapy is tiered. NSAIDs for early mild attacks, triptans to block trigeminal neurotransmission, gepants or ditans for patients with vascular contraindications, and antiemetics for nausea. Preventive options include beta blockers, topiramate, tricyclics, CGRP monoclonal antibodies, or gepants taken daily. Lifestyle regularity, sleep, hydration, meal timing, reduces attack frequency neuromodulation devices targeting supraorbital, vagus, or occipital nerves provide non-pharmacologic relief for select patients. Education on medication overuse headache prevents chronicity. Fibromyalgia is a chronic nociplastic pain condition defined by widespread musculoskeletal pain, fatigue, non-restorative sleep, and cognitive fog. Central sensitization underlies symptoms. The nervous system amplifies normal sensory input, lowering pain thresholds without tissue damage. Diagnosis is clinical based on widespread pain index and symptom severity after excluding inflammatory or endocrine disorders. Management is multimodal and functional. Regular aerobic and resistance exercise recalibrates pain processing. Sleep optimization addresses non-restorative rest, and cognitive behavioral strategies reduce catastrophizing and improve pacing. Pharmacologic aids, SNRIs, tricyclics, and anticonvulsants like pregabalin dampen central hyperexcitability. Opioids are generally avoided due to limited efficacy and risk address comorbid mood disorders and irritable bowel syndrome. Education that pain is real but centrally mediated helps patients engage in active self-management, leading to incremental pain reduction and improved daily capacity. Gout is an inflammatory arthritis caused by monosodium urate crystal deposition in joints due to prolonged hyperuricemia. When crystals shed into the joint, neutrophils ingest them and release cytokines, producing abrupt, excruciating pain, redness, and swelling, classically at the big toe, but also ankles, knees, and hands. Diagnosis is confirmed by polarized microscopy of synovial fluid showing negatively birefringent needles. Clinical algorithms assist when aspiration isn't feasible. Acute attacks respond to NSAIDs, colchicine, or glucocorticoids. Avoid starting or stopping urate-lowering therapy during a flare unless already established. Long-term control requires achieving a low serum urate target with allopurinol or febuxostat, and using prophylactic low-dose colchicine during initiation to prevent flares. Dietary sodium and alcohol moderation, weight optimization, and management of metabolic syndrome reduce flares and cardiovascular risk. Chronic uncontrolled gout forms tophi and joint damage, emphasizing adherence to targets. A herniated lumbar disc occurs when nucleus pulposus material protrudes through the annulus fibrosus and compresses a spinal nerve root. Chemical inflammation plus mechanical compression causes radicular pain shooting down the leg in a dermatomal pattern, often with numbness or weakness. Red flags like bowel bladder dysfunction or progressive neurological deficit require urgent evaluation. Initial management emphasizes activity as tolerated, NSAIDs, and targeted physical therapy to strengthen core muscles and reduce nerve root irritation. Oral steroids or epidural steroid injections can reduce inflammation in selected patients. MRI is reserved for severe or persistent symptoms beyond conservative care. Most cases improve over weeks as inflammation resolves and the extrusion dehydrates. Surgery, microdiscectomy, offers faster relief when disabling pain or deficits persist by removing offending fragments and decompressing the nerve root while preserving spinal stability. Peptic ulcers are mucosal defects in the stomach or duodenum caused by an imbalance between aggressive factors, acid, pepsin, NSAIDs, Helicobacter pylori, and defensive barriers, mucus, bicarbonate, blood flow. Pain is burning or gnawing related to meals. Gastric ulcers worsen with eating. Duodenal ulcers improve, then recur as gastric emptying delivers acid. Complications include bleeding, perforation, and obstruction. Diagnosis uses endoscopy, which also permits biopsy to exclude malignancy in gastric lesions, and non-invasive tests for H. pylori. Treatment eradicates H. pylori with combination antibiotics plus acid suppression and discontinues NSAIDs. When possible, proton pump inhibitors allow mucosal healing by profoundly reducing acid secretion. Lifestyle measures, limiting alcohol, tobacco, and irritants, support recovery. Refractory or complicated ulcers require surveillance and evaluation for hypersecretory states or continued NSAID exposure, ensuring durable pain relief and preventing recurrence. Gallstones form when bile components, cholesterol or pigment, precipitate into crystals that aggregate within the gallbladder. When a stone obstructs the cystic duct, the gallbladder contracts against blockage, causing biliary colic. Steady right upper quadrant pain radiating to the back or shoulder, often after fatty meals. Prolonged obstruction leads to cholecystitis with fever and leukocytosis. Diagnosis relies on ultrasound evidence of stones, gallbladder wall thickening, and sonographic tenderness. Labs assess inflammation and liver involvement. Uncomplicated biliary colic is managed with analgesia and elective cholecystectomy to prevent recurrence. Acute cholecystitis requires antibiotics and timely surgery. Stones migrating into the common bile duct can cause jaundice or pancreatitis and are removed endoscopically. Ursodeoxycholic acid may dissolve small cholesterol stones in patients unfit for surgery, but recurrence is common. Dietary fat moderation reduces symptom triggers, but does not eliminate stones. Primary malignant bone tumors and metastatic lesions cause deep, persistent pain due to cortical destruction, periosteal stretching, and microfractures. Night pain and pain unrelieved by rest. Our typical evaluation includes radiographs showing lytic or blastic changes, MRI for local extent, CT for cortical detail, and biopsy for histology. Management is multidisciplinary. Systemic therapy tailored to tumor type, local control with limb-sparing surgery or amputation when necessary, and radiation for palliation or definitive control in radiosensitive tumors. Bisphosphonates or denosumab strengthen bone in metastatic disease and reduce skeletal events. Stabilization procedures, rods, plates, or cement augmentation prevent or treat pathologic fractures. Pain control integrates NSAIDs, neuropathic agents for nerve involvement, and opioids when appropriate, plus palliative radiation targeting painful lesions. Early rehabilitation preserves function and mitigates deconditioning during treatment. Appendicitis results from obstruction of the appendiceal lumen by fecalith, lymphoid hyperplasia, or less commonly, neoplasm. Obstruction increases intraluminal pressure, impairs blood flow, and fosters bacterial overgrowth, producing visceral pain that begins periumbilically and localizes to the right lower quadrant as the parietal peritoneum becomes inflamed. Anorexia, nausea, and low-grade fever often accompany. Clinical scoring systems support diagnosis. Ultrasound or CT confirms inflammation and excludes mimics. Uncomplicated appendicitis is treated with appendectomy. Laparoscopic approaches reduce pain and speed recovery. Selected patients may choose antibiotics with close follow-up, recognizing recurrence risk. Perforation leads to abscess or peritonitis, requiring antibiotics and sometimes drainage before delayed surgery. Prompt recognition prevents complications and shortens the painful course. A tooth abscess is a localized pus collection from bacterial invasion of the dental pulp following caries, trauma, or periodontal disease. Pressure within the rigid tooth and surrounding tissues causes throbbing pain exacerbated by chewing or temperature changes. Swelling, gum tenderness, and foul taste are common. Spreading infection can cause facial cellulitis and airway risk. Definitive treatment removes the infection source. Endodontic therapy cleans and seals the root canal, preserving the tooth. Extraction eliminates the nidus when salvage isn't feasible. Incision and drainage relieve pressure and pain. Antibiotics are adjunctive for systemic signs or spreading infection, but cannot replace definitive dental care. Analgesia with NSAIDs and local anesthetics manages pain while awaiting treatment. Early intervention prevents osteomyelitis, sinus involvement, or dangerous deep neck space infections that escalate rapidly. Third-degree burns destroy the full thickness of skin, including nerves, resulting in a leathery, insensate eschar. Despite local numbness, surrounding partial thickness injuries and systemic inflammatory responses generate intense pain. Severity depends on total body surface area and depth. Immediate priorities are airway assessment, fluid resuscitation guided by standardized formulas, analgesia, and prevention of hypothermia. Wound care includes debridement, infection control, and early excision with grafting to restore barrier function and reduce sepsis risk. Long-term pain arises from contractures, neuromas, and neuropathic changes. Treatment combines scheduled analgesics, neuropathic medications, scar management with compression and silicone, and physical therapy to maintain range of motion. Psychological support addresses post-traumatic stress and pain amplification. Early multidisciplinary care reduces chronic pain and disability. Adhesive capsulitis is progressive fibrosis and contracture of the glenohumeral joint capsule, producing severe shoulder pain and marked loss of active and passive motion. It often follows immobilization or occurs with metabolic disorders. The course has phases: painful freezing, stiff frozen, and gradual thawing as inflammation subsides. Examination shows restricted external rotation and abduction. Imaging rules out structural tears. MRI may show capsular thickening. Management targets pain and mobility, NSAIDs and acetaminophen for analgesia, image-guided intra-articular corticosteroid injections to reduce synovitis, and structured physical therapy emphasizing gentle stretching within pain limits to prevent exacerbation. Hydrodilatation distends the capsule and can improve range. Refractory cases may require manipulation under anesthesia or arthroscopic capsular release. Early motion after shoulder injuries or surgery helps prevent capsular tightening and the subsequent painful stiffness that impairs daily tasks.